Welcome everyone to today's webinar, How Sutter Health is Unlocking Greater Value from its Robotic Service Line. I am Christelle Kazaka with Becker's Hospital Review. We will begin today's session with the presentation and will follow with the Q&A conversation. You can submit any questions that you have throughout the presentation by typing them into the Q&A box that you see on your screen, and we will be happy to follow up with you on any of those questions. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Rick Carell is the Assistant Administrator of Surgery and Cardiovascular Services and Adult Service Lines for Sutter Medical Center in Sacramento. Michael Benneke is the Medical Director of Robotic Surgery for Sutter Health in Sacramento. Thank you both for joining us. The floor is yours.
Welcome. My name is Rick Carell. I'm the Assistant Administrator for Surgery and Cardiovascular Services at Sutter Medical Center in Sacramento. We're very glad to have you here today, and we, as well as you, have partnered with Intuitive to build our robotic program. So a little bit about me. I started in Sutter Health as the Regional Service Line Executive for Cardiovascular Services, but in 2018, I assumed responsibilities for perioperative services at Sutter Medical Center. For this team, I'm the executive sponsor. I attend all of the committee meetings, operational as well as physician and peer and quality, and I recruit robotic surgeons to make sure that we have a complete robot-assisted program. And I derive those decisions and work with the physicians and partnerships to take the data and put it into an operational plan. We believe our robot-assisted program fits with our mission, vision, and values, and we try to make sure that everything that we do fits within that. Sutter Health is a very large health system, over $13 billion in operational income, and 40% of our patient population is government funded, but we do share a large population of commercial patients as well. We have 5 medical foundations, over 12,000 physicians, and we service over 3.5 million patients. For our robots, we have 11 programs in Sutter Health. We have 19 total systems. We performed in 2019 over 5,400 cases, but we consider Sutter Medical Center the flagship of our program. We now have 4 XI robots. 3 of them are in our main operating room, which provides inpatient and outpatient surgery. And then we have an outpatient facility that has a robot as well. Sutter Medical Center is 523 beds, 28 ORs, 24 of which are in the main hospital, and there are 4 in our outpatient facility. For our robot-assisted surgery, 48% of it is general surgery, 34% gynecology, and 18% urology. So it's been a 16-year volume generation. And this graph gives you a little bit of the information about how things have grown over the years. So between 2005, at the beginning of our program, and 2014, not a lot of organization. The program was not managed like a service line. It was a new piece of equipment that was placed in the operating room. People used it if they wanted to or didn't. But between 2005 and 2014, we grew from 94 cases a year to 541. Then we started focusing on bringing together the service line. Each of us has very unique stories about developing robot programs. And our journey started in 2005, and we've made significant changes since 2015 to improve the operational performance of the program, as well as to improve patient care. We celebrated in 2018 as we received our Center of Excellence designation, and we renewed that this year as well, and we're very proud of that. Being the flagship, being the best we can possibly be, is our motivation at Sutter Medical Center. We live in a world of value-based care, so we were looking for better outcomes, lower cost of care, better patient experience, and to the entire patient process to improve from our robot program. So in a value-based world, we have to determine some value. So we're driving quality. We're looking at the procedural mix so that we make sure we have the right kind of providers to provide a complete surgical program, and looking at the financial impact that we believe that if our quality increases, our financial impact will be positive as well. So we had a significant turning point. In 2014, we had 3 robots, 2 XIs and an SI. And then in 2015, our organization, 2 of our hospitals merged. Sutter General and Sutter Memorial became Sutter Medical Center Sacramento. And we reduced the number of robots from 3 to 2. But most importantly, in 2015, Dr. Michael Benneke became the medical director of the program, and we've benefited from his leadership over the last number of years. In 2015, let's talk about what's happened. 740 cases in 2015 with a direct cost over $11,000, but our profit margin was negative. Looking at the development of our program toward being world-class, we looked at it as achieving 4 phases. Phase 1, 2, 3, and 4, and 4 being world-class. Our improvement opportunities were many. Once we analyzed our information, we saw a lot of variability in practice. We saw a lot of variability in use. The robotic time that was used for block time was variable, inconsistently used. Our start times were variable. So we did everything from the basic up to the most complex. So we started looking at start times as well as we looked at turnover times and our patient outcomes. So change is difficult, and I love change when I lead it. So in 2015, Dr. Benneke came on board as our medical director. And the fascinating thing about Dr. Benneke is he was a convert. He was one of our surgeons that wasn't interested in robot surgery. And now he has become a person that is a role model for robotic services within our whole health system. We developed dashboards. We created a peer review committee to look at clinical cases, and we achieved our Center of Excellence designation in 2018. Data. Boy, do we have a lot of it, but it's not necessarily very informative. So we had to look at ways that we could marry the data that we had financially, we had an exhaustive amount of financial data, as well as our clinical data. Interesting thing is, we really had to clean up our financial data. So we believe that minimally invasive surgery improves the hospital economics for each one of our facilities if we embrace it and we optimize the program. Most important for us was we needed a dashboard to create some level of transparency as well as credibility to the program and the efforts that we were taking on. We never really want people to conclude that the only thing that we are concerned about is money. We wanted people to understand that we wanted to improve the care, and we felt that if we did that, the financial performance would improve as well. And that is what has happened. But we have seen significant reductions in our length of stay. As the reimbursement improves in the outpatient environment and our patients have moved more toward outpatient, we have benefited from that as well. With the recruitment of more physicians and the recruitment in the local market for more physicians who like to work in our clinical environment, we have seen an increase in commercial cases. As we look forward, our overall goal would be to continue to develop robot-assisted surgery going forward. For every patient that is eligible, we would really prefer there to be a robot-assisted surgery. Why? Because we think it's absolutely the best care. And for each one of the services that we provide, we try to optimize each one of those procedures so that we have the best results for our patients. Robotics. It's been very important to us. When the finance team approaches me and asks, can you use another robot for your program to grow more? Then I believe we were successful. So we have grown by 26%, over 1,100 procedures. And we can tell you that we improved operations with 2 robots to performing over 500 procedures on each one of the 2 robots. So to be best in class, to be world class, you look at other institutions that are role models. And we looked at Hoag. Hoag is in California with great credibility. And so we took our robot surgery team, every tech and nurse and the physicians to Hoag, and looked at everything that they were doing and let them share with us what they've learned from the process and the improvements that they had made in our organization. And this helped create even more motivation in our health system to improve. So as we have moved forward, we've taken the data. We have now acquired 3 XI robots in the inpatient environment or in our inpatient operating rooms, and we've added a 4th at the end of the COVID year. So COVID was very drastic to all of us, but in Sutter Medical Center, our robotic surgery grew during 2020, primarily because physician could actually get an operating room in the outpatient environment easier than we could in our inpatient environment. So we had some good results with COVID. Here are the components of our business plan. And business plans to me are not just a balance sheet. Business plans for me are look at everything exhaustive associated with the program and try to plan for everything that you know that you can plan for, because there will be a number of things that will develop over time that you haven't thought about, and you can spend all your energy managing the surprises. Here's our slide that shows our development toward world-class. There are 3 phases of development until we got to our world-class status. And it takes buy-in, it takes commitment, it takes constantly reviewing each component of the organization and of the program to look at ways that we can improve it. So between 2015 and 2019, we saw case volume increase from over 700 cases to 1,400. Our direct costs were reduced. Our contribution margins improved to 42%, and our profit margin went from a -4 to over 20%. Looking at all-cause readmission, a concern of an indicator that we're all managing very, very closely, you will see that robot-assisted surgery actually has the least and lowest readmission rate. Standardization, which easier to get people to buy in and reducing variation. How can we find the best results of our program and duplicate them in as many places as possible? And so we have continued to work at that year after year after year. People have figured out that we're really serious because we don't drop it every year. We continue to develop and move forward. Even though physicians may come and go, staff may come and go, our commitment to the improvement in the program and the reducing variability remains. Extended use. Extended use provided to us by Intuitive has also benefited our program. Over $250,000 was saved in the last year because we can use instruments on more cases than we could before. And this is, I think, a significant commitment from Intuitive to partner with us in the development of our robot program. Just the reduction of changing instruments has actually improved and reduced the cost of each individual case as outlined above. So it's just another component, and there are many facets that have improved the cost of care of this patient population. Less blood, less drugs, reusing instruments, all of those things work together to improve the operational performance of the program. Our journey continues. So in our journey of developing a world-class program, starting in 2019 and going forward, we don't believe that we have achieved everything that is possible to achieve. We continue our strategic meetings. We continue to work with our operations team. But what we needed was how to create a new environment for robot surgery. As I mentioned earlier, we removed an SI robot from our outpatient facility, and now I want to go and put one back. Sounds a little inconsistent, but our growth hopefully represents something that has worked where physicians would want to be in that environment. So Intuitive worked with our finance team into developing a shared risk model, and this allowed us to start the program without having the demand that we normally would need before we would acquire a piece of capital. We continue to look at opportunities for cost reduction as well as clinical variation reduction. So we signed the AMP program and in the year of COVID in 2020. And let me mention that in 2020 during COVID, our outpatient robotic surgery program increased in size. It was the area that grew last year. So we acquired our fourth XI robot, and we signed the enriched document in this year in 2021, and we look at how this will move us forward again into this world-class status. In the AMP acquisition considerations, we wanted to look at what was the benefits of using AMP acquisition process over acquiring capital. So we looked at the things that are important to all of us: quality, volume, our bed availability, the site of care, as well as access to capital. Most important in our organization is ICU capacity is generally zero, and throughput is very, very challenged. We admit over 100 patients a day to this hospital, but we generally only discharge 70. So we're always running at a little bit of a deficit. So any patient that we can provide care for in the perioperative experience and discharge is one less bed that we have to wait for and provide a bed for a medically patient. So decanting the OR is very important to us. Now we're looking at how we expand outpatient services and use this very nice facility that we have designed for that. And the AMP program was the best financial performance that we could generate at this particular time. The development of our world-class service line is all about transformation. It's taking all of the things of the past that we had achieved, everything that we had learned, all the buy-in, as well as consensus building possible. We use all of that information and we continue to move forward year after year in improving the program. So we've lived through phase 1, 2, and 3, and now we're trying to check off all the boxes in our world-class category. It's impossible to do it alone. Strategic partnerships are necessary to achieve the goals that you want to achieve. And Intuitive has been a very good strategic partner with us in developing with us a world-class program. So in summary, value-based care, we want to be the best performing, best quality at the lowest cost possible. We wanted to treat the robot-assisted surgery program as a service line unto itself, and we partner together clinically as well as operationally to do that. I serve as the executive sponsor for that, along with my partner, Dr. Benneke. The economics of robot-assisted surgery have been proven time and time again in our organization, and it is a result of the better care that we are providing our patients. Data, data, data. Whatever data you have, please use it, and use it consistently and timely so that you will have the buy-in and consensus building that is necessary to build a world-class program. And collaborate with Intuitive. Intuitive has many ideas. They've seen many plan designs and program designs. They have an idea for you about what will work for you, just as they introduced the AMP program to us. And now I have the opportunity this year to develop our outpatient surgery program using the robot.
Thank you so much, Rick. We'll now pass it over to Michael Benneke.
appreciate everybody's attendance today and welcome. So let's just kind of get started with the next phase of our discussions today. So just a little bit about me. I guess we always have to do this. It's a requisite. I trained locally at UC Davis and finished in 2002 and joined Sutter Medical Group at that time. And my practice was centered at Sutter Medical Center of Sacramento. And that's pretty much where I've been the exact same time my entire career. I didn't get robotically trained until about 2015. So I was doing fine for 13 years and then took on robotic training in late 2015. And then about 2 years later or so, I fell in love with this so much and took such an avid role in it that I became the medical director of our robotic surgery program. And you can see down below here with the graph on the bottom right, just sort of how the expansion of our program happened with respect to case volume over the last several years. And we'll go over that in more detail down the road. But really, it's sort of the story that we want to tell about how we get our programs to excel. And that's going to be part of the conversation today. So we're going to build that world-class robotic surgery program for everybody. So really, it always starts with figuring out who we are and why we're doing what we're doing. It's that clarity of purpose. It's knowing where you're headed and why you're headed there. And then really it's about finding that pathway to plan your course. And so that's this concept of true north that we always try to talk about with people, is that you got to start with that sort of inner feeling of knowing why you're doing this. And that's what it takes to become a world-class program. You got to have that vision from the get-go. And really, this is the same concept that Simon Sinek in his 2009 book titled Start With Why described. And in this book, he's talking about how great leaders can inspire action. And he comes up with this concept of the golden circle that a lot of you may have heard of already. So this concept is really about not just knowing what you do or even how you do it, but most importantly, why you do what you do. And that's that real center of purpose of vision for what everybody needs to understand. And that why really needs to be at the center of all the decision and the mission that we take on in our robotic surgery program. So that's really our goal. And you always want to start from that inside aspect of knowing the why and then communicate from that point out. So all that is really another way of saying that we need to know what our vision is. And that's really defining what our purpose is. And really our organization all has to have that. And so our robotic surgery program has to have the same thing. Why are we doing this? Why do we believe in it so fervently? And so back in 2015, my hospital, Sutter Medical Center of Sacramento, set out to sort of renew its robotic surgery program. At that point, we were just a bunch of individual surgeons who were doing robotic surgery without any formalized structure. And we really wanted to reorganize into a multi-specialty robotics program. We thought that only through that morphosis would we be able to sort of change the way we could provide the care to our patients. And so really at that time, our vision was to sort of make this a patient-centric experience. So we wanted to then therefore take and leverage a team approach to make and improve the provider experience, thereby making our place the program for where people would come to do their robotic surgical practice. And then we also wanted to utilize evidence-based medicine, efficiency metrics, and data to really drive down costs and improve outcomes. And really what we didn't know at the time is that we were describing the quadruple aim as our real objectives. And you can see that outlined here in this Venn diagram where all these things are sort of interrelated and they're all critically important. And this really is sort of the why, or our true north. It's the vision, and it's really what you need to have if you're going to start on a journey to become a world-class robotics program. So then it's really sort of the question of how do you get to that point? And it all sounds good. We're all leaders of some sort that are at this meeting here today. And some of you are executive surgeon leaders and others of you are administrative leaders. But all of us have some sort of leadership role. And so really it's about figuring out what we're trying to do to get to that high level of performance. And from an executive surgeon standpoint, it's really having somebody or a couple of people that have a lot of these attributes. And there's a big compendium of things here, but I really look at two things that I think are most critical in the attributes for an executive surgeon leader. And those are the two things highlighted here. That is, it's got to be somebody who really sees the entire forest, not just those trees that you're staring at. And it's somebody who can bring the people and the causes together. And I think these are critical aspects in order to take your program to the next level. And this is really the concept then of bringing people into alignment. So it's sort of a transformative leadership process when you can align a group of people. It's sort of this multi-directional communication deep listening, lots of dialogue. It's going to take a lot of time and patience. There's going to be some moments of frustration. There's going to be mid-course corrections as you go along your pathway. But it's really what's necessary if you plan to achieve and sustain a high-performance program. So that alignment is just another way of saying we got to be able to create teamwork. And as Michael Jordan here states, talent wins games, but teamwork and intelligence wins championships. And Michael, as great of a basketball player as he was, he may have been a better motivator and the ability to bring people together to actually allow them to achieve a higher level of performance than they would have been without his oversight. The other thing that becomes necessary is that we have to have people who are willing to step up and maybe be a catalyst for change. And as Tim Cook would say, you want to be that pebble in the pond that creates the ripple for change. And I think for a lot of times in our programs, there's some aspects we need to change that culture. And that's, as an executive surgeon's primary role, is to really change the culture when the culture needs to be changed. And so this is all talking about vertical alignment. Okay? And so really kind of what do we mean by that? And vertical alignment is more of a concept of getting everybody together from sort of not just a top down and a bottom up, but just having everything go through all different layers so everybody's on the same page with the same vision. And this really requires 3 pillars to actually make your program an excellent world-class program. And it requires these 3 things: clinical excellence, operational excellence, and executive leadership. And they're 3 very, very similar, but yet distinct concepts, and they all have different categories. And you'll get a little bit of information on each of these today. You already have gotten some on the executive leadership side with Rick's presentation earlier, and you'll see some more later with some of the operational aspects as well. We'll talk a little bit about the clinical excellence sides of things today as well too. But more again, from a robotics program standpoint, there's more than just 3 pillars that are required. We also have to make the consideration that there are 4 different stakeholders. And each of these stakeholders have much different priorities to some extent. At least that's the way it looks from the outside. But when you actually sort of review what the priorities of all these stakeholders, you'll see that they're not that dissimilar. They're pretty close. But we always have to keep in mind that no matter what surgeon's priorities are, or the executive or the OR administrator's priorities are, it's most important that we keep the patient's priorities in the forefront. And so what does the patient want? They want safe care, high quality care. They want it to be affordable, and they've got to have that positive experience. And they need equitable healthcare. That is, everybody needs to get the care that they deserve. So then there's also just this concept of creating this, well-organized team that we have to be empowered. And so we have to give them that ability to feel empowered. And it's going to require several different concepts. We have to have that great support from the top. And with that great support, the operational staff become empowered and the program flourishes. And certainly this achievement comes from all these different factors: the consistency of the program, the leadership, the communication styles, and the accountability. So all of this, when you put them together, allows for well-trained staff, allows for 24/7 access in a program, dedicated OR rooms for better access for all providers, and then the active leadership engagement and the effective communication that comes for the vision and for the sharing of the outcomes. We also want to be able to develop the culture of accountability and for continuing education. So these are the things that you really need to do to sort of empower and allow your teams to flourish. There's also going to be lots of different alignment gaps. As you're trying to create a culture of change or bring people together in an alignment, there's going to be these gaps. There may be budgetary issues, access issues, efficiency concerns, data, or teammanship. So these are all things that you're going to run across that's going to make a necessary change in order to make your program excel. So as you know, and you've seen this diagram earlier, this is the program maturity model that we have for how you can develop your program from sort of an early stage program or a phase 1 over into a world-class program. And what you'll see is that all of these things can change, but they require certain different philosophical differences. Some of them require changes in belief or in the coordination of things or in the access of things. So for example, If you need to sort of change things to become a world-class program that you believe are more beliefs, there are frequently going to be things that talk about the cost of ownership or restricted case mixes or systems that are underutilized or that the surgeries maybe take too long. If we have issues that are maybe from a coordination perspective, we're talking about that maybe we don't have an executive sponsor or no operational leader, or really maybe we don't even have a robotic steering committee at this point. And then there are sort of access issues. Sort of, is there some block underutilization? Or can we expand into after-hours surgery? Can we standardize the fleet so it's a single platform? Maybe it's all XIs. And can you work on an outpatient strategy? So these are all important things to help your program develop to the next level. All of this really, though, starts with the robotic steering committee. This whole alignment process in developing your program starts with those solid fundamentals of that steering committee. So our steering committee really has a very formalized structure. It has a charter. It's an official document that I'll show you that outlines the goals and the rules of engagement. But then in our meetings, it's not just a free-for-all where everybody talks. There are actually Robert's Rules of Order. We try to actually make this a very formalized structure. There's a cadence where early on, maybe we're meeting monthly, but as you mature in your program, maybe bi-monthly or quarterly is fine to meet. And then there are agenda items. We want to be able to set those items and stick to it so we have a definite plan for each meeting. And then there's the critical aspect of the dashboard. You're going to have to formulate that dashboard, put certain things that you find germane and critical to your institution in that dashboard. Show it every single meeting. Update it as frequently as you can. Let everybody know. And we're going to monitor all the different trends that you find valuable, whether it's on-time starts or turnaround times or block utilization. And the other concept is you want to start developing policies. And as your program matures, you're going to start looking into things about developing policies that are somewhat preemptive and preventive down the road. And we'll talk about some of those things that we've done. And then also the committee, from our perspective, also oversees lots of different events, whether they're CME events, community outreach, philanthropy engagements, pro forma development, or just providing focused recognitions for a job well done. These are things that our robotic steering committee takes to heart. So here is our charter, and you can see it's just a 2-page document. It talks about the purposes of the committee, the activities and the responsibilities, the roles and relationships, the committee members, and really the operating rules of the committee. So something that you want to formalize, put it together down on paper, and hold people accountable to it. So this is just a historical volume for our program. And to some extent, this just describes, I think, the importance of the robotic steering committee. So our program started in 2005, really with a single S standard system, and then moved on to the SI in 2010. But by about 2014, obviously, we were expanding and moving into the XI realm with the fourth generation. And it was really at that point where we had to start making changes. And that's when we sort of got together to retool a robotic steering committee group. And it's that point where you start to see things take off. Now, yes, we did change platforms, but what's important to notice is that you'll see in 2016, we actually dropped down from 3 systems to 2 systems. And yet we were able to continue to increase our volume. And the reason that that volume continued to increase, in my opinion, is wholeheartedly because of the robotic steering committee and the efficiency metrics that we set out to achieve. And that allowed us to continue to expand our robotic surgery volume. Okay? So that was critical. I can't stress that enough, that we became so much more efficient by having this system set up and in place. So just talking about some of those clinical excellence considerations. Okay? So I'm going to just go over some of those brief aspects. So you have to have that executive surgeon leader. And it's also important that you have sort of very high standards for credentialing and recredentialing. And we'll show our documents that talk about that. Then we're going to talk about all those other things, the supply costs, the case length comparisons, length of stays, etc. We're going to talk about the peer review items that we see, the generic screens and the patient safety reports. And then we're going to track and measure all-cause readmission rates and emergency department visitation rates. So not only people that got readmitted to our hospital, but also that showed up in another ER and were seen and treated there. And then we also want to talk about the ancillary programs. And some of these things we'll save for another day, but some of these things we'll dive into right here and now. So here is our recredentialing document. So as we all do, every 2 years, We all have to recredential. And so back when we retooled our program in 2015, we changed our case volume from 24 cases in 2 years to 48 cases. We effectively doubled that number overnight. And we grandfathered people in. But as your program matures, you're going to be allowed to do so, because you actually can't have dabblers in a program that's trying to be super efficient. So we hold people accountable to demonstrating that they've done 48 cases in the last 2 years. And they don't have to be just at our institution. We just want them to be having their hands on the instrumentation and doing the work robotically in order for them to continue to keep our program efficient. The other things that we look at, and this is an example of a slide that I've created, which is just looking at sort of length of stay. And this clearly makes a big difference for your executives when you're having that sit-down conversation. And this is a chart that I created, and it was very simple. I looked at my colorectal cases, basically my sigmoid and my low anterior resections that I started doing robotically. And I looked at the first, this is now 65, and there's been more after that. But I just tracked the length of stay of these patients, and I put them on a graph. And you can see those are the individual green dots here. And then the red line is really just a 10-case moving average. And if I compare that to what I was doing for my last way of doing colon surgeries, which was a hand-assisted laparoscopic colectomy, my length of stay decreased by a delta of 2.4 days. And so this is just critical information for your executives to understand why they need to get buy-in for this. Because a 2.4 day decrease in length of stay is huge for throughput of patients. So these are simple, easy graphs to create of ideas that are very, very simple and germane. And you want to share this with your staff and all the people that participate in your program. We also have this very robust robotic peer review committee. Okay, now this is actually a subcommittee of both the departments of surgery and OBGYN. So we've set it up so our robotic cases are not reviewed in those individual department meetings, but rather at this shared event, which is a peer review protected event. And it's comprised of both departments members, and urogynecology, gynonc, urology, general surgery sit on this committee, and we review all charts that come in on robotic cases. We also have medical staff support. We have hospital administration there with the business managers. And we have ad hoc members as need be, and we meet bi-monthly as well to talk about all these robotic cases that get presented. And so we also have a committee charter for that peer review committee. And it, again, talks about the structure, the goals, the process, membership, and the confidentiality aspects to this. So we want this to be, again, very formalized structure. And we thought it was important that we embrace and monitor our own peer review ourselves. And then we report back to the individual departments. And the things that this robotic peer review committee looks at are triggers that include the patient safety reports. These are the quality concerns that get flagged. And then there's the generic screens, such as a readmission of a patient within 30 days, or an unplanned return to the operating room, blood transfusions, intraoperative consult, and conversions to open. Not again that any of these things are bad, but these are just things we want to be able to review. One of the other things that our robotic steering committee takes charge of is creating preemptive agendas. So we want to be able to foresee what may be troublesome down the road. It's sort of like doing a SWOT analysis. And really, we wanted to be able to find things that keep our operational efficiency to its maximum. And so this document, what we call our robotic downtime prioritization guideline, was born out of an episode that happened where one of our robots, and we have 4 at our hospital, 3 in the main OR, and one of those systems arms was broken off in the middle of the night. And so it became evident that we needed to figure out what would happen if one of the robotic systems went down. Who would get their cases canceled? So we developed a whole point system that comes in play if all three rooms are robotic and they all can't decide who's going to lose their cases for that day. So this is just a point system that people can utilize. And we hold people accountable that if you have the highest point total, you're going to be allowed to do your cases. If you have the second highest point total, you are also going to be allowed to do your cases. But the lowest point total would therefore have to cancel his or her cases. The other things we wanted to start addressing is another policy that we developed, which is a robotic surgery advanced surgical scrub role policy. So this is a policy, again, to help increase the efficiency for scrub techs to be the sole bedside assistant for robotics cases. Currently at our institution, it had always been that we needed to have a licensed professional, so either another surgeon or a physician assistant or RNFA at the bedside. But now we're trying to really increase and expand the ability for people to do cases, especially the simple cases. So we wanted to be able to define what the scrub techs could assist on to be the sole bedside assistant on what we call simple cases. So we developed this whole policy, and we went through a training program for them to develop and test their skills and make sure that they were adequate to be an advanced surgical scrub. And then finally, one of the other things we've recently done is we've rolled out a robotic assistant learning program. And so this is really a program to help facilitate the credentialing of privileges for our mid-levels, the physician assistants or their RNFAs. So rather than them having to go out of town or even out of state to get certification and a training, we are now doing that in-house. So we're actually developing this in-house learning program to be able to teach them so that way they can get their credentialing without having to go through a formal training course elsewhere. So we'll talk a little bit about some access management strategies, and it's very important. And we'll talk about some of the things that we've done. They may work for you, they may not. Nothing's definitely going to be a cookie cutter mode, but we're definitely going to hopefully give you some thoughts about what you can do to try to increase your access management at your institution. So we always talk about past, present, and future for all of our institutions and our programs. And for robotic block time and utilization, we've had a couple of things. And we've evolved from what we did back in 2015 or even before to where we are right now. So currently we have the luxury of having sort of a single platform. So that really helps us be more efficient just on the start. And we can book into any of those rooms, and it's all standardized. We also have fairly dedicated robotic rooms. Each robot platform system lives in its own operating room. It does not get moved from room to room. Although our goal is 100% to be exclusively doing robotics in those rooms, it's not quite, but that certainly is our goal. And we try to keep a robotic room open when they're not all being utilized for emergency add-on cases. Okay. We also then therefore have made it a goal to train the majority of our scrub techs and our circulating nurses to prevent any kind of staffing roadblocks that might be present. Okay. And so all this is really about trying to help the emergency add-on cases as well be available for after hours and weekend time. So we're really trying to improve that utilization characteristic pattern of our program. And we have lots of sort of block time expectations as well. And this is a topic that a lot of people are always interested in. And so our institution has really an 80% block utilization goal. Okay? And I also have sort of a personal internal goal that 1/3 of our block time needs to be open or unblocked for people to be adding on cases, or for new surgeons who want to come in and do cases who just don't have the luxury yet of having block for them or their group. And then really we also only want to provide full day blocks. Half day blocks have a tendency to be wasted time. Either you're spilling over or you're done early and the room stays fallow. So we strongly encourage full day blocks for everybody. And then if people aren't utilizing to the threshold, they start to get warnings after the first quarter. And then they're subject to redistribution of their block time or takeaway of their block time if there's no changes seen after that second quarter. And we want to share this data, and we share it monthly or quarterly with all the surgeons so everybody knows where they're at. And we do this not just for the robotic cases, but also for all the rooms in the hospital, in the OR. So we set very clear definitions. We want to have the robotic steering committee collaborating with the main operating room's block utilization review committee. We're going to track case length times and hopefully hold people accountable to using that average time when they book cases. So that way they're not over or under booking, and they have to actually use their actual average time. And then we're going to use some of the other aspects to make the emergency cases and OR add-on emergency cases much more efficient to be able to be placed on by keeping a room open whenever feasible. Okay? And this is all about communication. So we got to be able to talk when a block gets released. We have to set up a program such that our surgery schedulers can let the staff know or let the surgeons know when a block has been released. And so that communication plan is critical. And then there's lots of operational goals where you're going to monitor things and set up aspects for you to demonstrate the performance metrics. And these are just some of the considerations you have for actually measuring non-operative times in your operating room. It can be looking at the first case on-time starts, which we do. You can be looking at the wheels in to the first incision time, or the incision being closed to the wheels out for the patient. And then also the wheels out from one case to the wheels in or turnover time for another case. And these are all things that we look at consistently because we want to have that operational excellence. And we want to share all this. So we demonstrate this at our meetings on a fairly consistent monthly basis. And here is one of those documents that we have, a first case on time start document, where it just looks and shows what exactly we're doing and who the offenders might be if there's a case that's not starting within 1 minute the scheduled start time as that first case of the day. So this dates back to actually 2019 data, but I wanted to throw it up here because it shows where we started in 2017, where we were only 56% on time. And then it took a couple of years, and we're finally starting to get closer, and we now certainly are above 75% for our first case on time starts. And we track down below who the actual individual surgeons or anesthesiologists or nurses are that are the cause of the delay. And then if we have repeat offenders, we're going to actually sit down and have a conversation with those individuals. And then it's also important to know that your turnaround times should be no different for robotics than for any other surgical procedure that's done. So as you can see here, the robotics service line has a turnover time average in 2019, and we just use that prior to COVID, as a 33-minute turnaround time. And if you look at it, that is almost the exact same turnaround time as it is for the other specialties that use it in their non-robotic cases, such as general surgery, OBGYN, or urology. So it's critical that everybody assumes robotics is going to take a longer turnover, but you have to demonstrate that it's actually not. And the expectation is they are exactly the same or potentially better. And you want to let people know, a job well done. Focused recognitions for the whole team when they achieve these metrics. And then it's critical to have this sort of whole robotic dashboard. So this is something that we've had. I think most institutions are going to have some sort of a dashboard. There's 24 metrics that we have listed on here, and they span financial, growth, clinical, and operational aspects. And you can see we actually have annualized metrics and performance goals. I mean, that's the critical thing. Don't just set out and tell you what you're doing, but also actually have a beginning of the year performance goal so you know where you're at and whether you've achieved that goal or not. The other thing that's quite important from an executive perspective, whether you're a surgeon or an administrator, is to know that you understand that there's more than just the granular things that we do on a day-to-day basis. You need to see and understand that there's more than just trees out there, that there's a big forest, okay? And so it's about knowing that the total cost of healthcare is not just the capital costs for the things that we purchase, or the instruments, or the service plans, or the overtime that we pay our nurses and staff, but rather it's all these other things that are potentially below people's radar. Okay, it's the length of stay, it's the readmission rates, it's the complications and surgical site infections, or the disability and the return to work time. If you can get people back from a societal perspective, that's an improved total cost of care. So it's critical that you understand that and demonstrate to your executive team that you gather that information and that you find it prudent and very, very germane to your program's vision. So in 2019, Sutter Health, my parent organization, we set up this robotic surgery symposium, and it was critical. Our executive team supported this whole process, and its origins of this symposium was out of Sutter Health's supply chains robotic utilization work group. So this is really the grassroots effort of containing costs, but it really expanded from this. And when we had our 11 robotic surgery programs meet in 2019, we talked about operational things to really maximize the efficiency. And really, as a healthcare entity, if you and your healthcare have not sat down and done this across all different programs within your healthcare, you're behind. You need to sit down and have this collaborative discussion. It's clear that this collaboration fosters the growth of all the programs. We don't want people reinventing the wheel at each location. Okay, it's critical that you set this symposium style process up. And then it's really the question when you're all said and done, how do you know when you're successful? Okay, what's that impact quantification? And for us, it was pretty simple. Okay, we wanted to be able to demonstrate that we had improved patient experience scores, that we had improved physician engagement and staff experience of work scores. We wanted to have stable or decreasing direct costs and increasing contribution and profit margins. And we wanted to have improved clinical outcomes. And again, if you look at all this, this is that quadruple aim. So really, you can measure these things and get back to your original reasons that you're doing these things, that quadruple aim, that stride that you're making. Okay, and so as an executive surgeon, there's just some takeaways that we're going to leave you with. Okay, you need to assess your program. You got to make sure you've got executive staff and physician participation. You got to know what matters most to each of those stakeholders. And you've got to have, most importantly, that clarity of purpose. Okay? Why are you doing those things? And you got to keep that why at the center of your program. You got to keep bringing it back up. And you got to really align around that vision. You got to get everybody on the same pathway. Okay? Put it in writing. Got that charter, commit to it, bring it forth, review it every couple of years. Then you want to secure your executive sponsor. You want to identify and align with that sponsor and relate exactly why you have this vision for your program. And again, improved outcomes, decreased length of stay, improved patient satisfaction. Those are the things you want to be demonstrating. Then you got to assemble your program. And that really starts with that robotic steering committee that we talked so much about. And you got to develop that dashboard. And really, this support, you got to support all this with the clinical, operational, and the executive excellence pillars that you're going to learn about today. So again, I want to thank everybody. I know this is sort of a high-level discussion, but certainly we're going to be around to answer some questions later on, and I look forward to those conversations. Thanks. Have a great day.
Thank you, Rick and Michael, for that fantastic presentation. We will now begin today's question and answer session. We welcome any questions that you have, and you can submit those through the Q&A box that you see on your screen. The first question here is, how has the evolution of value-based care impacted the hospital's initiatives?
A couple of other points I would say is this. We also have an internal issue of demonstrating value. We're all competing for the same capital, the same resources. And so we also want to make sure that the decisions that are internally being made are based on a value orientation as well. I don't have to work specifically with contracting with value-based care, but I'm pretty confident, and my goal always is to make sure that the care that we provide and the cost that it takes is always something that the contracting staff can use to make us competitive in the marketplace.
Great, thank you. The next question we have is, how do dabbling surgeons affect value-based care?
You know, part of the program that you have to devise in any place that you're doing this is really going to be based on the culture that you develop there. And from our perspective, there's a mentorship that has to happen. So as the good fortune that I have to be the medical director for this program, you know, and as an executive surgeon leader, I take that role as a mentor. And so it's all about us just trying to elevate each other's games. And so it's giving that efficiency. Now, there are some people whose practices just don't allow them to be super busy on the robot because it is just a small component of what they do, but it's very, very germane. And we do everything we can to sort of propagate a higher volume user. So we've set up some credentialing items that really make a big difference. So one of the things that we always talk about is just sort of our volume for credentialing in robotics. So every 2 years, we all get re-credentialed. And for us, about in, I think it was 2016, maybe it was early 2017, we just basically doubled the volume that we need to do on a 2-year cycle basis. So we went from, I think, 24 cases at that time to having to have 48 cases under your belt to be recredentialed for robotic privileges. If you don't have 48 cases in the 2-year interval, that doesn't mean you can't do robotics. What it does mean, however, is that we make people go back and do some simulator time and then have a couple of cases proctored again, and then they're good for another 2-year cycle. So we do everything we can sort of on a mentoring process, and that's that culture that we develop here, where it's not punitive, but we're trying to encourage people to be high volume users and frequent users to make the whole program be elevated.
Great, thank you. The next question here is, how do you ensure that your robotics steering committee meetings are productive, and what's the format?
Yeah, so I think productivity is all a matter of setting up the culture for your program. Again, culture is a big word for me as well too. But we expect that we're not just sitting here meeting so people can check off a box of attendance. So we have a tendency to sort of sit down and actually come up with ideas. I mean, for me, when I sit down, I'm actually looking for things. What can we do next? And so there's just this creativity, and I think that just provides a little bit of energetic flow to the program. So we have this sort of formalized agenda, and I'll sit down now with Lisa a couple of days before our steering committee, and we just sort of formalize and go over the entire format. But we've generated these ideas of what our topics are going to be through the month or 2 months before the steering committee meets. So we just set these out in a formalized agenda. And we sort of act, Lisa or myself, as the sort of agenda defender. So we're going to keep people on task, and we sort of don't let things get off task too much in terms of the topic. It's a very formalized process. If we're going to vote on something, we're using Robert's Rules of Orders. I mean, this is, as I mentioned, it's not just a conversation where people just start shouting things out there. And then we sort of start off and we talk about, in an individual meeting, we start off with the good things, the welcomes and the wins. So new people joining us and what's happened since the last time we met. Then we give Intuitive actually a little bit of a moment to sort of give us updates on the latest, greatest things, such as potentially the extended use program, things like that. And then we have those formalized agenda items that we talk about. And then toward the end, we go over all the different metrics that we have and the dashboard items and just kind of review kind of what our status is over the subsequent quarters. So that's kind of the approach that we take. And I think just having that type of a formalized structure brings the engagement. So you get the surgeons and the administration and the staff all wanting to actually come and participate because they know that you've got the vested interest in it. So they certainly want to be there as well.
Wonderful, thank you. So follow-up questions here for Dr. Benneke and Rick. You both talked in your presentations about having the 3 different pillars: operational, clinical, and executive leadership representation on the steering committee. What's the best way to get commitment from all 3 pillars to attend the steering committee meetings or task force meetings?
Yeah, I can start, Rick, if that's okay. So I think the best way to get engagement, is that should be the culture of expectation that you're going to be engaged. And so I view my job as medical director as a little bit of a cheerleader. I mean, I'm that Marsha Brady every once in a while where I'm just getting people excited about doing stuff. And then ultimately, when you're having the meeting, you got to discuss all of these 3 pillars. You got to discuss the clinical, the operational, and the executive things at each one of these meetings. So you don't just promise something and then not deliver. So you got to actually talk about these things to keep people interested. So that's the way I think we get people to actually show up and participate in this, is to cheerlead a little bit, but then actually produce the product and talk about those things that are important, whether it's clinical outcomes, whether it's cost efficiencies or length of stay reductions, or peer review, kind of where are we with complication rates and readmissions and things like that. So I think those are all important. We talk about all the different metrics that we have, the turnaround times and all the dashboard items, and those just become very, very important. And you just got to keep driving those home.
I have the simplest job description there is, and that is all I do is make sure that my staff and the physicians can take care of patients. That's all I do. And if I do that, that's the commendable part of my role. And so being there, being supportive, answering the phone when something comes up, when Dr. Benneke has an issue even before the meeting, and everyone else, everyone just is really committed to having the best program possible. And so when you have that, what you want to do is you want to provide the contribution that you can provide. I am perfectly fine going to a meeting and never saying a word if I don't need to ring in. But what I'm trying to do is just to make sure that I can provide the resources and the support that the team needs to be successful. And when they show their clinical outcomes and patients are better, and that's why we do this, then I believe I've, done my job.
Great, thank you. What has been the impact of the improved structure that you've put around your program regarding surgeon satisfaction?
Connecting the dots is always the important thing. You want to know what's important to the surgeons, and it's primarily, first and foremost, the quality outcomes of their patients, and then second, time, and don't waste any. So what we try to do is to be very, very aware of what the expectations are of the group and where the group wants to go. I have very little imposition on this team. They've really become the role model team within perioperative services and maybe even within the whole hospital team. And so they've just really always been the ones who've always stood out as the leaders in the situation. So what we want the surgeons to do is if we say we're going to do something, we do it. If you have block time, I'm going to have you staffed. If the anesthesia has to get there, that's the partnership between anesthesia and administration to make sure that there are no delays. And so we work at all of those pieces all the time. And when it came to a point where we needed to look at a block service that wouldn't slow down the beginning of the cases, then it was my role to make sure that I was able to secure those resources by which for us to provide that adjunct program for the success of robotics. So we never stop. And there is never a time that there isn't a surgeon with a recommendation or a criticism. Listen to both.
Wonderful. The next question we have here is, how does reducing variation in the OR impact operations from your standpoint?
There was a time I loved best of breed. Right? Everything, whatever the chief or the best item was, that's what I thought we should do. And then we realized that it was virtually impossible to keep people competent on every possible thing that's best of breed. So the simpler that you can provide a service, it really is the better. It's more important than it being the cheaper decision, because everything else, if it is streamlined and you reduce the variability, the SPD staff know what they need to do. They can get the equipment there on time. The staff can move in any room. The rooms are designed the same. All of those simple efforts give you the ability to bring this highly trained group of people together in the most efficient way possible. And so that's what reducing variation does. Every time you have a lot of variation, you're not really sure exactly what you're producing. It's a bit chaotic, if nothing else. And so what you want is for people to be able to look at a situation and say, we've optimized this, and yet we still have one more recommendation about how we will improve things. But the team has really pushed the reduction in variability. I just support the fact that it's a good thing to do, and whatever barrier I can remove for it to achieve it.
Great. The next question here, can you tell us about your HOPD strategy, where you're seeing success and where you're seeing opportunity?
Well, we have an HOPD that's attached to our hospital, but you walk through 2 different buildings to get there. So it's in an odd position, but it's a very, very nicely designed facility that we have always a bit underutilized. And I say that because we may admit 50 patients in the morning to surgery. 25 of them will need an inpatient bed, and the other half go home from the main OR. So the question is there a better environment to put those patients in that still meets the surgeon's needs, the staff needs, and everything else? And so we were to a size where we needed to experiment a little bit because you have to achieve a lot of things. We just can't put a robot in a different location and say, okay, now it's there, go there and work. Because it has to flow with the block schedule and to make sure the surgeons necessarily are working after themselves. So as a result is how to use that space the best we can for the patients that are appropriate for that environment. The larger the volume of patients in that environment makes that environment much more valuable. It also makes it more viable. It's the same facility that has all the x-ray, the laboratory, and all the diagnostic services in it. It's easy access. Patients can pull right up, walk in the building, go out. Transversing our main hospital is a challenge for anyone. So all of those things as to how do you make it a very inviting environment, and this facility was. And we thought that physicians, the more they looked at it as an opportunity and they know they wouldn't be risking care, would be willing to go into that environment, even with robotics. And so as a result, I was the person who returned the third robot. And I was the interim leader at the time. And I promised myself, if I ever had the opportunity to come back, I would get the third robot so that we could move forward. So, so all of those things together, and how the outpatient strategy is, I'm competing against ASCs. Why in the world do you go to a hospital outpatient facility unless it has technology and better providers than the ASC, which is cheaper?
I'll just throw just a few comments into that. So from a surgeon's perspective, the reason that the HOPD strategy works great, as a general surgeon, there's a lot that I do that can go home same day. But what's critically important is the efficiency metrics. So the turnaround time in our HOPD is half of what it is in the main OR. So from a surgeon's perspective, that is absolutely where I want to be if that's my world. So there's no question that the HOPD has made my world, from a very selfish perspective, an improvement.
Wonderful. When it comes to new surgeons starting out, how do you suggest they get started with data? What data do you think is the most important, and what should they make sure to capture right away?
Well, I can give you my experience. So when we rolled out and retooled our robotic steering committee, and we sort of came up with ideas for our dashboard, I think we listed some 20-something metrics that we wanted to see immediately for our robotics program, and this is back in 2016 or so. And to be honest with you, that's hard. That's a hard ask, because you got to start with a small group of easy objective numbers. So from an individual surgeon's perspective, what made a difference for me is literally monitoring the length of stay of my colorectal patients in my practice specifically. So that made a big difference for me personally. And I did that myself. The institution can certainly provide that, but I kind of wanted to just know it myself. So that's what I started with. Certainly makes a big difference. And, from a hospital's perspective, it is important that from a value-based care, we understand what the readmission rates are, or even the returns to an emergency department. We need to know what the wheels in to wheels out times are, the turnaround times. All those things are great, but those are going to be more things that the system or the hospital will provide, as opposed to an individual surgeon who, if he or she wants to accrue their own data, start with a simple thing. A length of stay is an easy thing for you to keep track of. So, and going forward, it's going to be a lot easier with the outset of the My Intuitive app, which everybody will start to have access at some point here, to have an idea of what their individual stuff is like, and what that means for the efficiency of them in their world versus their competitor or their counterparts across the US. So that's going to be a very, very helpful application to start utilizing for everybody. So everybody should start looking for that. And certainly, we certainly work with Intuitive, and I've had lots of data come to me from my Intuitive reps about how I'm doing things, as well as how I should be doing things, or how I'm doing in comparison to people in my region or across the United States. So it's been a very helpful collaborative situation for me to work with my Intuitive reps over the years.
Okay, another question here. Rick, you guys have gone from 2 to 3 to 4 robots and have now expanded access to nights and weekends. How did you initially address surgeons that wanted more time and maybe weren't happy about not getting it? And also, how did you navigate when surgeons first wanted access to nights and weekends? And what did that transition look like?
So, block committee manages block allocation.
Okay.
Not me. And that's the only thing that people don't have to hate me for. And so as a result, the group says, we need more time. We need more access. And Rick, you get to make that decision, which meant every robotic surgeon called me almost every day until I got the third robot. Because it was creating a limitation for them that you don't want to happen. When you have a lot of surgeons who do a lot of work, you don't want to waste their time. And so looking at that, we realized that it would be to our benefit, which to create some capacity. Just because we could do 500 plus cases on a single instrument did not mean that that is sustainable forever. Would people hang in there with us not having access? And the answer would be no. So as a result, what's your goal? Your goal is anybody who's going to operate and is going to do a good job and take care of their patients, you want them to have time in your operating room and commit to it. And what we try to do is to win everyone who comes in the door, and we generally do, win them over that this is a better environment for them to work in. And so you have to constantly buff off the staff and all the things necessary to be able to do it. The first decision and major contribution I made was the acute surgeons wanted to be able to do surgery later in the evening with robotics. And I said, spend the money to do it. That's all I did. I just told the OR leadership, do it. And they came up with a plan about how to achieve it. And you take a deep breath because you worry about competency, but the team owns so much, the surgeons are so involved, and it would be successful because of their contribution. So you just want to make sure that the environment is also inviting to the surgeons as well.
Wonderful. A final question here. What is the biggest benefit of the transformational changes Sutter has experienced in becoming a world-class robotics program?
I'll start, I guess. So, what I've sort of seen, I think, is just this whole culture. So, I talk about the fact that before we sort of did version 2.0 of our robotics program, which was basically we didn't have a version 1.0, but when we retooled it, it clearly became just the whole dabbler surgeon just doing whatever they want to just this collaboration environment. So there's no question that we talk about these things. Now, there isn't a day of the week or the weekend that somehow I don't get asked something about robotics. And so it is just a constant part of my daily life. And it's not just mine, it's the rest of the team. It's everybody else that's been presenting with us today. And it's the people who you didn't see, the extra 100-something people that make this program work. So they all work together, and we saw that improvement, and that makes a big difference across these pillars of the clinical, operational, and executive aspects. So that culture changes all that stuff, and you see that in the end results of what you're really looking for. And then ultimately it boils down to what we think has happened, or what we know has happened, that the patient outcomes have improved. I mean, we've seen that decreased length of stay and that decreased readmission rates to the emergency department. And that's really what sort of drives this home. And that's what the difference makes is for when you get a well-functioning team. And that's why these types of events where we talk about and collaborate together become very, very helpful to share ideas, because we don't want to just keep what we know here. We want to propagate it across the region and across the US when available.
I agree. It really is culture, because if you want surgeons to work in your facility, the patient outcomes are determined by your staff. Your staff are really going to be a deterrent or an invitation to work in your operating room. So the idea of the culture makes it all work. You can't spend enough money to get people to work together cohesively and want to be there together and be energized, it just won't do that. But when the culture transitions and the surgeons and the staff are working together and you just remove barriers as a leader, that new surgeons will come, the surgeons that are there will get better, and as well as patients will come with the surgeons, and word of mouth. We generally operate on everyone's family member, staff, as well as physician's family. And we're very proud of that. People choose us when they know the inside of our organization. So that level of credibility happens because the environment is such and the culture is such that it's a dynamic situation that's exceptional all on its own. And there are 200 people in there. This is not a staff of 15. So we're just proud of it. It is the culture.
Thank you both so much. That is all the time we have for today. I want to thank Rick and Michael again for their excellent presentation and Intuitive for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.